All right, I don't have any disclosures. So let me start with a little bit of an introduction. There's still a lot of unresolved issues, right? How do you deal with a neck? And we used to talk about a hostile neck, but nowadays I think we're kind of just saying the neck. Is a 2-centimeter neck really a good neck, or is it a bad neck? And that's the holy grail of endovascular repair. That's where most of our failures happen. Open versus endo. What is better long term? And this continuous debate about small aneurysms. Unfortunately, there's no new data to answer this question. There is a randomized trial that's gathering some support to see if women should be repaired at a smaller size or not. Currently, we do have some limitations on IFU, a neck length greater than 4 millimeters, diameters, angulation. And we all know that if you go off these IFUs, you usually have bad outcomes. That's been pretty well studied, and nothing new has developed so far as I know, to address these limitations. Let's talk about some basic techniques that people are using to overcome some of these limitations. Endo anchors, which is fairly easy to put. This is one of my cases. These patients do pretty well. These patients do have what you would probably consider a hostile neck, although there are quite a few operators that routinely place endo anchors to try and prevent failure from that site. The anchor data, the 4-year data, is quite promising. I think one of the positive things is that you have good sac regression despite hostile anatomy. I think that's an important thing to keep in mind, because I think sac regression is usually associated with better outcomes. We used to always say, well, your aneurysm hasn't gotten bigger, so we're probably doing okay, but we're probably not. I think sac regression is something that we may want to start looking into more carefully as we go down the road. When we look at ZFENS, the final 5-year results of the United States trial, at 67 patients, their mortality rate was quite low. At 5 years, freedom from aneurysm-related mortality was 97%. There were some issues with the renal artery patency early on. So renal artery primary patency was 82% and secondary patency was 97%. They had very few endo leaks. They had very few sac enlargements, and they had no ruptures or conversions to open. So we know that this technology is quite good, and it's gotten better, and a lot of people are using it. This is a case that I did quite some time ago, when we start doing Snorkel Chimney procedures for complex repairs. I mean, a lot of people do this. This is a technique that originated from salvage of previous repair of when you covered the renals. It is a quick off-the-shelf solution. If you have a symptomatic aneurysm that comes in and you don't have time to make a fenestrated device or a physician-modified device, then this is something that you could possibly consider. We've had some trials and some data that looks into it, and the results are encouraging. They're not superb, but they're okay. And there's really no consensus right now on which device to use. So if you ask everybody here, I'm sure everybody uses different stent grafts, different covered stents. There's a lot of mix and match that kind of goes on. But this technology or this technique has been fairly well studied. I mean, we've had multiple papers looking into it, and all of these papers have kind of given us an idea of how we should do these procedures. We shouldn't excessively oversize. What are the complication risks? These are not straightforward cases. These are quite challenging. And there's a learning curve, and there is a complication rate from doing this kind of a procedure. There are some limitations to doing Snorkel or Chimney cases. You have to have a new sealing length. When you start looking at your renal arteries, the diameter has to be fairly decent. They can't be cranially facing, otherwise that becomes a little bit more challenging. If your proximal access or your aorta is quite shaggy, then obviously there's a risk of having a stroke. And you have to look at your iliac access also to make sure that it's okay. So when you look at the 2019 European guidelines, it's the technique recommended in urgent cases of when fenestrated is not possible. So let's look at some Snorkel Chimney versus FEVAR. So this is the State of Complex Endovascular Aortic Aneurysm Repair and the VQI initiative. And they looked at about 1,400 complex cases that were done and just started comparing, what are people doing? What are the results? And you can look over here, actually, the number of centers performing these complex repairs from 2014 to 2017 is actually going up. And when you look at the different types of repairs, in 2014, there were few fenestrated devices, but when the last checked, the fenestrated devices, the uptake has been significant. Physician modified, I would say, has probably remained stable. Snorkel Chimney grew slightly. I think that people are probably using it a little bit less, but I think it's still quite prevalent, and you may see it at your institution. So when you compare FEVAR, which is the fenestrated versus physician modified versus Chimney Snorkel, I think it's quite evident that most of these trials will show you that Snorkel or Chimney cases do have higher complication rates with stroke. I mean, these are tougher cases. These patients are usually urgent. They have more complex anatomy. So the complication rate is high, but it's not horrible. When you look at the Kaplan-Meier survival curves, if a few years out, the patients do okay. There might be a slight dip, but these patients are alive. Let's talk about the distal landing zone a little bit, moving away from the proximal. I think it's key to preserve blood flow to at least one internal iliac artery in this day and age. I think the SVS guidelines and the ESVS guidelines essentially, give it a level 1 recommendation that if you can, you should preserve them. When I trained, we used to embolize both hypogastric arteries, and now we know that that's probably not a good thing because it does affect quality of life significantly. So again, this isn't a case that I did. It's just an iliac branch device case. This technology is quite good and able to preserve it. Gore has good data from the iliac branch device cases now. The pain C at 3 years was, for the external iliac, was 100%. Internal iliac was 95%. There was zero bladder claudication. There was no erectile dysfunction. And as far as the size of the aneurysms, they actually did pretty well. So this really does improve quality of life. So I think, we do that. So open versus endo. We've been kind of going back and forth. And I can tell you that the pendulum keeps swinging. We were very endo heavy early 2000s or up to mid 2000s. I feel like the paradigm is shifting a little bit. A lot of us are now contemplating, what is a good next? Should we really be doing endo? Should we be doing open repair? I can tell you that this year itself, I've done about 7 or 8 open repairs, which is more than I would normally do. Just give you an example. Here's a 60-year-old male. He has a 6-centimeter aneurysm. He has a very small neck. Obviously there are many options that you could do. You could do fenestrated. This is probably not a good case for a straightforward endovascular, but it would probably need some sort of fenestrated or a physician-modified device. The guy's asymptomatic, so you do have time to make a fenestrated device. Let's look at some data about endovascular versus open repair, and look at the randomized controlled trials. We know that 30-day mortality favors endovascular. In-hospital mortality also favors endovascular. But as you start going long-term to 4 to 8 years and greater than 8 years, we actually know that open repair has a much better aneurysm rate related mortality. So we're starting to notice this with the devices, that as you go long-term, these devices do fail. What's a 5-year reintervention rate after endovascular repair? It's 21%. That's fairly high, and the 5-year rupture rate is about 3%. So that's why these devices have to be monitored for the rest of their life. There is some, if you have ruptured aneurysm, if you're Black, if your aneurysm is large, these patients do require more intervention down the road. So that patient that I showed you, I actually did an open repair. The patient was young. They actually did really good, and they're doing fine. This is another lady that I treated this year. Again, very complex aneurysm. She was 80 years old, large aneurysm. So I did a physician-modified endograft. Again, these are fairly complex cases, but it came out really nice, and she's actually doing well. And this is the completion angiogram right there. There's some new data from NYU. Fenestrated endograft repair promotes positive neck remodeling and greater sac size shrinkage. So when they compared their Z-FENs versus EVARs, they actually noticed that in the Z-FEN cases, there was more sac regression than they had in their EVAR cases. So again, this is the whole thing about the neck, and does the Z-FEN actually stabilize the infrarenal neck, and do you get more sac shrinkage, which may actually lead to a better outcome? So that begs the question: should we really be doing EVARs, or should they all be some sort of a fenestrated device? When you look at the UK guidelines, they've actually updated the guidelines in March 2020. And their recommendation is actually open surgical repair should be performed for unruptured AAAs if the patient is physiologically able to undergo that procedure. So you can see this paradigm is shifting, because they're not recommending really endovascular repair unless you have a ruptured aneurysm. SVS had some guidelines. They were published in 2018. Elective EVAR should be performed in institutions that do at least 10 cases per year, and open also should be performed in institutions that do at least 10 cases per year. I was asked what's the most dangerous size. When I trained, we were told 5 centimeters, because if you don't fix it, someone else is. And this is a big problem. This was just published recently. SVS database was queried. 38% non-diameter compliant EVARs were performed. So that's bad on us. We should be, obviously there's some issues with the data, but I think we have to be more careful as to what we're doing. There's some good upcoming technology that a lot of centers are in trials with TAMBs, P branch, T branch. I think in the next few years, we'll have a much better understanding of where we're heading as far as the neck goes. Look at that, 0 seconds.